we go further. So I have a few questions to you. All of you give me the answer. What is the best initial test? Morning 8 a.m. cortisol test, right? It should be less than how much? 100 nanomole per liter. What is the best diagnostic test? Confirmatory diagnostic test? Short-acting test, and there are so many names. Basically, it is the synthesized form of the ACTH. So you gave, but the cortisol did not rise more than how much? 420. It is still less than the 420. Then we say that patient is having the adrenal insufficiency. But now the question is whether it is primary, secondary, or tertiary. Then we need to do another test. What is that? Long-acting test. By the way, we are calling it short because we are waiting for how long time? Only 30 minutes. So now we are going to do the long-acting test. If the problem is not in the adrenal gland, right? If it is not in the adrenal gland, problem is the secondary or tertiary, then the cortisol level will increase now. But if the problem is the adrenal gland, the cortisol level will still not increase, and we can say it is the primary Addison disease. And if it is the secondary and tertiary, then we can do another test called as CRH stimulation test. We will give the CRH. If the ACTH increase, the problem is in the hypothalamus. You give the CRH, but the ACTH is still down, then we say the problem is in the pituitary gland. What idea? So in this way we do the testing. Okay, so I have some questions to you. All of you tell me, what is the most common sign and symptom of the Addison disease? What is that? Weakness and fatigueness. And tell me the two causes of the weakness and fatigueness. One is the decrease in the sodium, and the second one is what? The patient is also having the anemia. And of course, don't forget, if the cortisol level is less in your body, it means glucose is also less. So it can also contribute to the weakness and the fatigue. So many things can contribute here, but two things I wanted you to know: sodium and the anemia. By the way, in case of the Addison disease, will there be increase in the eosinophil or not? Yes. Tell me the two reasons for that, two probable reasons for the increase in eosinophil. One is the decrease in amount of steroids in the body, and second is what? The autoimmunity or allergy? Allergy, right? So don't get confused. We call it autoallergy. And you tell me, in the Addison disease, the antibodies are produced against which part of your adrenal gland? Which structure of your adrenal gland? The 21 hydroxylase enzyme, and that's why it causes the autoimmune adrenalitis. Clear about this thing? Okay, so now the last part of the Addison disease we need to learn about is how to treat this patient. And never forget, just now I gave you the idea about the diagnosis. You tell me one thing: if somebody came to you with the adrenal crisis, with the acute adrenal insufficiency, are you going to do all this thing? The short-acting test and the long-acting test? You first do the treatment, right? And then you look for the diagnosis later on. First you save the patient, and then you think about the confirmatory diagnosis. If your suspicion is very strong, then you begin the treatment instantly. And whenever we begin the treatment, keep in mind, we generally use one drug. This drug is going to be dexamethasone. If you need to be confirmed about the treatment, then we begin this drug. What is that? Dexamethasone. And why we give this dexamethasone? Because dexamethasone does not embark on the short-acting test or the long-acting test. If we give this steroid, then this will have no effect on the short-acting test or the long-acting test. And we are going to give the dexamethasone only in that situation when we need to confirm our diagnosis. But if you are almost sure about your diagnosis, then we don't go with the dexamethasone, we rather go with the IV hydrocortisone. Right, so we don't go with the dexamethasone, we go with the hydrocortisone. Okay, so now very quickly, let's go for the treatment of the Addison disease. So first of all, let's begin with the Addison crisis or the adrenal crisis. What do you think? What is the most important treatment for the Addison crisis? Patient came to you and he is about to die. What should be you giving him first? Right, the most important treatment is going to be steroid. Are you going to give in the oral form or the IV or IM form? Right, so you are going to give him the either IV or IM. Keep in mind, the hydrocortisone, you give in the oral form, you give in the IV form, or you give in the IM form, all of them are same. Hydrocortisone. Hydrocortisone is going to be equal efficacy in case of IV, IM and oral form. So remember that the first treatment here is going to be the steroid, and the best steroid we give here is which one? Hydrocortisone. But never forget, if you are required to confirm your diagnosis later on, then you are not going to begin with the hydrocortisone, you are going to begin with which one? Dexamethasone. Clear about this thing? So how to give the hydrocortisone is going to be like this. We are going to give the 100 mg, and we keep on repeating 6 hourly. So every 6 hours, suppose this patient came to you, you give the IM or IV hydrocortisone, then you are going to again see the patient after how many hours? 6 hours, And if still he is required some steroid, then again you are going to give it. And how long to give it? Answer is until and unless the patient is stable. So we keep on repeating the hydrocortisone 6 hourly, and generally it takes 24 hours when the patient is stable. And once the patient is stable, after 24 hours, generally we convert the IV hydrocortisone into oral hydrocortisone. Right? So we are going to repeat the hydrocortisone every how many hourly? 6 hourly. Another very important thing, never forget that if the patient came to you with the additional crisis, we must also give the fluid replacement. Right? So fluid replacement is the second very important aspect of this treatment. And how to give the fluid is like this. We give around 1 liter of the fluid within 30 to 60 minutes. We give it very fast. And of course, don't forget, if the patient of the additional crisis is also coming to you with the hypoglycemia, is it possibility or not? Yes, additional crisis patient can come to you with the hypoglycemia. That at that kind of situation we can add 50% dextrose. So along with the fluid therapy, we will be also giving the glucose hypoglycemic therapy. We can add the 50% dextrose. Right? Okay. Now go further. Whenever we are going to do that, the another very important aspect of the treatment of the adrenal crisis is going to be that we manage all kind of electrolyte imbalance. If the patient is having high amount of sodium, treat the sodium. If the hypernatremia, if the patient is having very low amount of potassium, then treat the hypokalemia. Isn't it? Because the patient of the Addison disease is going to have the hypernatremia, and patient of the Addison disease is going to have the hypokalemia, isn't it? So, Addison is going to have the hypernatremia or hyponatremia? Hyponatremia, not hypernatremia, don't sleep. And then patient is going to have the hyperkalemia, right? So, we need to balance, we are going to maintain the balance of electrolyte. So, whatever electrolyte is imbalanced, we are going to balance it, maintain the balance of electrolytes. And mainly the two things we are going to be careful here, that is going to be very high amount of potassium and the less amount of sodium. So we need to treat them. And of course you know that the potassium is not going to be imbalanced in case of the secondary and the tertiary hypoadrenalism, right? But in the primary we need to care about both sodium as well as potassium. Also you need to control about the glucose. So I told you, if the patient is having hypoglycemia, what we should be adding? 50% dextrose. So this is the treatment of the adrenal crisis. Now the question is, what is the treatment of adrenal insufficiency? Let's say the Addison disease, the Addison's disease, or you can say, what is the treatment of the chronic adrenal insufficiency? How to treat it? Chronic one. And the chronic is very commonly treated in this way. If somebody is having the primary hypoadrenalism, right? If somebody is having the primary hypoadrenalism, think about this. It means the patient is having the problem in the pituitary, hypothalamus, or adrenal? Adrenal. So if there is problem in the adrenal gland, is the patient going to have only deficiency of glucocorticoid or even the mineralocorticoid? If somebody is having the primary problem, adrenal gland problem, is there only problem in the cortisol or also the problem in the aldosterone? Both. Right. So in this patient we must give the glucocorticoid. This is the mandatory one. We must be giving the glucocorticoid for them. We must be giving the hydrocortisone to them. But we also need to add what? Mineralocorticoids. We must also give the mineralocorticoids to them. So glucocorticoid is mandatory, but the mineralocorticoid also is required to be given. Can you give me one example of the mineralocorticoid? The most common example of the mineralocorticoid in our body, the glucocorticoid, you know that there is the hydrocortisone, right? So very common example of the mineralocorticoid. Guess, you can guess it. It begins with F. Oh, it means you don't know, right? So we call it fludrocortisone. So the very common example is fludrocortisone. So fludrocortisone is mainly going to have the mineralocorticoid property, but the glucocorticoid property is mainly going to be seen by the hydrocortisone. So fludrocortisone is mainly by the mineralocorticoid, and don't forget how I remember it is that in case of the mineralocorticoid, right? In case of the mineralocorticoid, there is going to be mainly the balance of the sodium and potassium, isn't it? And whenever the patient is having the problem with the sodium and potassium, then they are also going to have the problem in the water, the fluid. So I remember this way, fludrocortisone, the fluid, so mineralocorticoid. By the way, I think I forgot to mention one very important thing, the very, very important thing in the sign and symptom of the Addison disease. You go back, have I mentioned over there the low BP or not? You tell me, in case of the Addison disease, when it is primary disease, when there is less amount of sodium in the body, will there be more fluid in the body or less fluid? less fluid, so patient will get the dehydration, and patient is also going to have the postural hypotension. Right, so whenever the patient will change the position from the sitting to up, then suddenly their blood pressure is going to be down. So you mention over there in the sign and symptom. I don't know how I forgot to tell that. So in case of sign and symptom, you must mention that patient is going to have even the postural hypotension. Hypotension. But this postural hypotension may not be very clearly seen in case of the secondary and tertiary hypoadrenalism, because you already know the secondary and tertiary hypoadrenalism is not going to have the deficiency of aldosterone. So maybe this hypotension will not happen over there. So don't forget, this is more commonly with the primary or secondary? Primary, right? So same like the hypertension, which is more commonly with the primary, the postural hypotension is also very common with the primary, not with the secondary and tertiary. So don't forget, if the patient came to you and he is having the postural hypotension, then you must add the fludrocortisone. You must add the mineralocorticoids. Clear what I'm saying? Now the question is, how generally we give the hydrocortisone? What is the dose of the hydrocortisone? So never forget, generally hydrocortisone we divide them into 2 to 3 doses, and generally we go for around 20 to 30 milligram per day. And we give them in the 2 to 3 divided doses, right? So 20 to 30 milligram per day, and we divide them into the 3 doses, 2 to 3 doses generally. And the larger dose is given in the night, because you know that in the early morning the patient is going to have the requirement of high cortisol, so we must be giving in this time. Clear what I'm saying? Okay, now let's go further. That if somebody is having the secondary, or let's say the tertiary hypoadrenalism, do you think we need to give the mineralocorticoids? No, because the aldosterone is normal, because this patient is not having the postural hypotension. So we are not required to give the fludrocortisone, we are only required to give them the glucocorticoids. The dose will be almost the same. So we only give the fludrocortisone, but we don't give the mineralocorticoids. Clear what I'm saying? So we have only given the glucocorticoids for them. And we also treat the main disease here. For example, suppose a patient came to you and is having some adenoma in the pituitary gland, and that's why the problem is there. So we first need to treat that problem also. But we must replace the cortisone level here by giving the glucocorticoids. Clear what I'm saying? Now there are few things you must not forget. You tell me, what is another name of the cortisol? The stress hormone or the anti-insulin. So keep in mind, if somebody is having the hypoadrenalism, we always ask the person to take some hydrocortisone with them all the time, right? Because suddenly it can lead to the adrenal insufficiency, the crisis one, the acute situation. So these patients should never miss a dose. We must counsel them very well that if you miss one dose, and you already know, patient is taking the steroid for long time, and today he missed the dose. Can he develop the adrenal crisis or not? Yes. So we must counsel them very well that we are giving you this steroid, but you should never miss a dose, number 1. Right, so I want you to write down. So there are going to be some advices that we must be taking care about this thing, that we should give them the advice. The number 1 advice is going to be never miss the dose. And the second advice is very important, that whenever patient will go through some moderate amount, a little amount of the vigorous exercise is okay, a little amount of exercise is okay, but whenever somebody goes to moderate exercises, for example, let's say somebody planned that okay, tomorrow is the weekend, so let's do cycling, and in the exam they are always going to use this one, cycling, that a patient is having the adrenal insufficiency and he is under glucocorticoids and he plans to go to cycling. What should be your advice to him? So remember, whenever a person is going for the moderate exercise, for sure don't say that okay, you don't do cycling. That's not a good thing. These patients have the freedom to do anything they want, right? But whenever they go for the moderate exercise, then they must increase their dose of the glucocorticoid by at least how much? 5 to 10 milligrams. They were taking how much? 20 to 30 milligram, but whenever they go with the moderate exercise, then they must be taking how much? 5 to 10 milligram. Clear what I'm saying? But now suppose this patient came to you and he said, doctor, I want to participate in the marathon. And marathon is a moderate exercise or the very vigorous exercise? Vigorous exercise, right? So only giving 5 to 10 milligram extra is going to help him? Not at all. So if there is the vigorous exercise, and in the exam they are always going to give you the long distance running, sometimes they may give you the marathon. So in this kind of situation you must know that we must double the dose. right? So we must double the dose. Never forget, we are talking about the glucocorticoid, we are not talking about the mineralocorticoid. So the glucocorticoid should be increased by 5 to 10 milligrams and glucocorticoid should be doubled. So if he is taking 30 milligrams, now he should be taking 60 milligram, right, before he begins his vigorous exercise. Not only that, sometime when some patient is going through some major surgery, and you already know surgery is a stressful situation for the body or not. So whenever a person is going through some major surgery, right, then again we must inform the surgeon, we must inform the anesthesiologist, and we must double the dose. Clear about this thing? Suppose that a patient have developed very severe trauma. A patient have developed a severe trauma. Then again we must double the dose. Patient have developed a very severe infection. Severe infection. Then again he must be double the dose. So very stressful situation in the body, for example vigorous exercise, for example major surgeries or severe trauma or severe infection. In this kind of situation we must double the dose, otherwise patient will develop your body will behave as if there is no steroid and patient can develop the adrenal crisis. And adrenal crisis, you already know, is a life-threatening situation. Also got idea? And don't forget that the patient should never miss that dose and they should be always taking the hydrocortisone with them, and whenever they feel some kind of problem, right, then they should be taking one salt. Same like in the hypoglycemia, we tell the patient to take some sugar. Here we tell them to take some steroids. Okay, now the last thing about the adrenal insufficiency I must tell you, right, keep in mind, you already know that sometime when somebody is having adrenal insufficiency, especially the autoimmune adrenalitis, for example the Addison disease, then the patient are going to have some associated features. After this I will talk about that one. So they may have some associated features, associated other autoimmune disease, and one of the very common one is the Hashimoto thyroiditis, right? And the feature of Hashimoto thyroiditis will be almost similar to the Addisonian crisis. Now imagine a patient came to you and he is having all these features, his TSH level is high, his T3T4 is down, and he is having almost the same feature of the Addison crisis, which can even happen in the hypothyroidism. Let me tell you, if you made a mistake in diagnosis, if patient was having Addison disease but you diagnosed he was having the hypothyroid crisis, then you gave him the thyroxine hormone, let me tell you, suddenly he will go in the Addisonian crisis and he is going to die. So never forget, if you have the suspicion, you have the confusion between the Addisonian crisis and the hypothyroid crisis. What idea? So first you should be giving him the treatment for which one? Addisonian crisis. First prepare his body to fight the stress, give him the hydrocortisone, and then you wait for some time and then see what is happening to the thyroid, and then you can see whether it is really Addison crisis or thyroid crisis, right? The hypothyroid crisis, less amount of thyroid in the body. So always remember this point, that whenever you are confused between the hypothyroidism and the Addison crisis, and you know Addison crisis, we don't wait for the confirmation of the treatment diagnosis. So rather we give one dose of what? IV hydrocortisone, and then we see for the diagnosis. So in the exam they are going to trick you. They will give you one case and they will say everything, and everything will look like person is having hypothyroidism. They will say what to do next, and they will say that thyroxine. And as soon as you will give the thyroid hormone to the patient, you already know thyroxine is going to increase the metabolism in your body or decrease the metabolism. And if you increase the metabolism without giving the stress hormone, without giving the cortisol, the patient will go in the further Addisonian crisis and patient may pass out. Got idea? So always keep this thing information in your mind. So in this way I have finished the Addisonian crisis, and now we will have 2-minute break, and our class is finished. So I will also give one extra knowledge to you just for 5-10 minutes, that is the autoimmune polyglandular syndrome.